Good evening, everyone. Thank you for joining us tonight for Adult ADHD lecture, part of Chris O'Brien Lifehouse CPD series. My name is Lydia Connick, and I'm a CPD program officer with Central and Eastern Sydney PHN. Also working with us tonight, Lauren Thomas, antenatal shared care and CPD program officer. Tonight's session, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work and meet tonight. I recognize the continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I also would like to extend that respect to Aboriginal and Torres Strait Islander peoples joining us tonight. And now I would like to introduce our facilitator for tonight, Dr. Kenneth Tonk, member of Inner West GP Education Advisory Committee and our local GP. Taking this opportunity, I would like to thank Dr. Tonk and our speaker tonight, Dr. Charles Chen, for the extensive work that they have contributed towards adult ADHD education and the additional activities. Thank you, Kenneth. Over to you.
Thank you, Lydia. Good evening, everyone, and thank you for joining us for this webinar. I understood that we have well over more than 100 registrants, and it's an excellent to see that so many people are interested in the area, and it's justified our decision to run this topic. And we're very fortunate enough to invite Dr. Charles Chen, who is actually quite an expert in this area, and I can testify to that. I have a number of patients that actually see Dr. Chen regarding the condition. And may I just introduce Dr. Charles Chen, who is actually currently a consultant adult psychiatrist, and he's a director of the Mind Oasis Clinic in Sydney in Strathfield. He graduated with his medical degree with the University of New South Wales in 2005. And following that, he done a lot of rotations and training through the various hospitals, Concord Hospital, Royal Prince Alfred Hospital, and then he completed his psychiatric specialist training in 2014. And he also have earned another degree in Master of Psychiatry and also completed an advanced certificate of forensic psychiatry through the College of Psychiatry. Dr. Chen has previously worked as a consultant psychiatrist in a number of public sector as staff specialist with the New South Wales Justice Health. He has also worked extensively at a number as a VMO at a number of practices, including St. John of God at the Richmond Hospital and also at the Burwood Hospital. Dr. Chen has also worked as a consultant research psychiatrist at the Brain and Mind Research Institute, focusing on mood and sleep disorder. Dr. Chen obviously have a special interest in the treatment of adult ADHD. He is particularly interested in using a holistic approach in optimizing patients' functional outcome. Without further ado, I'd like to hand it over to Dr. Charles Chen to give us a rundown on the current management of adult ADHD. Thank you, Dr. Chen.
Great, thank you, Kenneth, and thank you, Lydia, for organizing this talk and inviting me to be a part of it. I'm really grateful to have the opportunities to talk about adult ADHD, which is a very special interest of mine. I'm sure our audiences would have some experiences when they have patients presenting, requesting for an ADHD assessment. And I think in the last maybe 10 years, definitely in the last few years in Australia, we have seen a lot of awareness in adult ADHD. We've come from a place where, say 15 years ago, most people believe that ADHD only exists in children, and they will simply grow out of it when they turn 18. To now, I think with a lot of the work by a lot of goodwill clinicians, researchers, and advocates, I think adult ADHD has become a lot more well accepted. A lot of people are coming out to seek ADHD assessment. So I guess for us as a psychiatrist, it raised a lot of issues. That the sheer number of ADHD presentation has really made me and make a lot of us think, well, how can we as a psychiatrist cope with the workload. You know, something I think needs to happen. And I think to our GP colleagues, I think it raised similar, you know, issues, and there may be some unique challenges. You know, I think there probably not a lot of training in adult ADHD in a GP lens. So hopefully, I guess from my talk tonight, I would like to see our GP colleagues to have an approach. They would develop an approach how to assess patients who is coming to have an ADHD assessment. Also to develop a knowledge base on, you know, how do you refer, who do you refer, and a little bit of a basic of what are some of these ADHD management options are. And lastly, to also develop some confidence in how to monitor patients who are on stimulant medication under the guidance of specialist psychiatrists. So I'm going to use a case study to illustrate the following points. So including how are we going to make an initial diagnosis of ADHD in adults, any screening tools that GP can use, what's the best referral pathway, what's the process, so how do we as a psychiatrist make the diagnosis, what are the treatment options, you know, how is the adult ADHD different from pediatric ADHD, how long can we prescribe stimulant medication for a patient, is it going to be lifelong? And lastly, and quite importantly, what's the GP's role in the monitoring process? So I'm going to come to this. Hopefully, the case study will make it quite, you know, bring some color to the presentations. So I'm going to call this patient Emily. And when I first saw her, Emily was referred to see me by her GP, specifically for ADHD assessment. So Emily is a 46-year-old university academic. She's completing her PhD, majoring in linguistics. And she was in her final year when she first came to saw me. She's originated from Hong Kong and migrated to Australia with her families when she was 15 years old. She has a partner of 7 years. I'm going to call him Brett. Emily has a daughter from her previous marriage. And then Brett has 2 teenage daughters of his own. Emily lives with Brett and Brett's 2 daughters. Interestingly, Brett also has a diagnosis of ADHD. And he was diagnosed some years ago and has been taking Ritalin with some good response. So Emily presents to me because she read about ADHD and she realized that, oh, this explains a lot of her lifelong problems. And when she saw me, she provides me a very typical list of ADHD symptoms. She tells me she's always an airhead. She's so distractible. She can't get things done. She's always on the go. She's always go, 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 difficult to sit still. Her mind just won't stop. And as a result, she always feels very tense. In fact, that's what she always feels. She doesn't really understand what does relax actually mean. And she finds it hard to turn off when she goes to bed at night. So I asked her a bit about her clinical history, and we get some collateral history, and they all support a childhood onset of these symptoms. It's been there for a long time. It's just they never talk about ADHD when Emily was growing up in Hong Kong back in 40 years ago. So it's been a fairly pervasive pattern. And partly because of this, she has relationship problems with Brett and his daughters. She has academic difficulties. She's always caught by procrastination. She leaves things to the last minute. and she can be quite obsessive. She write everything down. And so because, you know, she's so distractible, so she realized if she write everything down, well, at least she can go back and check things. But, you know, as her academic, you know, progresses, you know, she's now doing her PhD. It's just the sheer demand of the work has made it incredibly difficult to maintain her academic functioning using this sort of scaffolding. So now if you see Emily, when she asks you, do I have ADHD? What would you think? Does it look like a typical ADHD presentations? What else can it be? What are the differentials? So I want you to have a think and maybe reflect on it as we talk about our cases. So now I want to bring out these screening tools, and because I think a lot of the GP colleagues, when you see someone comes to you, well, I think this ADHD questionnaire could be useful. Well, sometimes the wait list to see a psychiatrist could be months away. So what can you do in that, you know, in the initial period? Well, I think some of these, you know, questionnaires can fill the gap. The one on the left, the Adult ADHD Self-Report Scale, or in short, we call it ASRS. It's very well validated. It's easy to use, and it's, you know, about 2 pages long. It's a very good question, you know, screening tools. The one on the right, the Vendor Utah Rating Scale, is also quite commonly used, I think these 2 questionnaires could be like a starting point if you have seen someone like Emily. If she asks you, well, is it ADHD? Well, maybe this is some questionnaires that you can bring up and really about starting the conversation. I mean, you can also use it in, you know, in someone who you suspect may have ADHD. And so I think this sort of questionnaire is, you know, you can ask the patient to bring it home, bring it back in the next consultation. Is always a good starting point for that conversation. Another one that I think is quite useful is it's called the Jesper Goldberg ADHD screening. It's also, you know, quite well validated. And the last one is called DIVA. Now, DIVA is a lot more detailed and is a lot more, I think there are many pages. I mention it because I think some of the patients when they do a Google search, they may, you know, find this. But the DIVA could be a bit more complicated to administer, and, you know, it can be quite overwhelming. So probably as a screening tool, I probably will just stick with the first 3 screening questionnaire. So just a little bit about, you know, how do we psychiatrists make assessment? So we usually take about 1 or 2 sessions to complete our assessment. ADHD is a clinical diagnosis. So it's a bit like when someone comes to see us for depression or anxiety, or if they have mood swings, or if they have cognitive problems. So at the end of the day, it is you know, in psychiatry, most of the diagnoses are based on clinical assessment. It's based on the story. And ADHD is no different. And I always say that, you know, when patients call our receptionist, what we promise them is we will make sure they're going to have a comprehensive psychiatric assessment. It's not an ADHD assessment. It doesn't guarantee you're going to have ADHD, or we're definitely going to give you a stimulant. But what we can guarantee is a very thorough psychiatric assessment. We always ask about everything, about your mood, your anxieties, your developmental history, so we can get a good formulation. So going back to Emily, when we asked her a little bit more, she tells me that she actually 4 years ago has a diagnosis of major depression in the context of academic struggle and family stresses. At the time, her parents were not accepting Emily's relationship with Brett. So obviously, her parents are Chinese and Brett is a Caucasian. So there may be a bit of a cultural clash there as well. So Emily was treated with valdoxin or aglomelatin, 25 milligrams at that time, 4 years ago, and she has been continuing to take it for the past 4 years. She finds that it helps her sleep, but she felt that there's still residual anxieties. It hasn't responded to the aglomelatin. She also saw a psychologist at the time who mainly used a CBT model. There was no ADHD mentioned at the time. So over the time, Emily managed to get better. She's certainly not clinically depressed. When I first saw her, I could not elicit any manic or hypomanic symptoms. I mean, there are some features of impulsivity, but it seems to be more in keeping with ADHD rather than a bipolar disorder in which you may see impulsivity more episodically. So medically, there was a history of Hashimoto's thyroiditis. So she was treated and has been euthyroid on regular blood tests. There's no other history of other medical problems or substance misuse. There's no family history of mental illness. Although, having said that, it's not uncommon in Chinese families, as mental health is often a taboo topic, especially in the generation when Emily was growing up. So Emily described a lot of her family members as quite loud, impulsive, and chatty. I mean, we can wonder if there are some ADHD traits going on in the family. She has a previous marriage of 12 years. It ended after a fairly acrimonious separation. Emily still maintains contact with her daughter. Before her current academic study, Emily has worked in many jobs. Similarly, in a lot of people with ADHD, they jump from different jobs. The longest one being a music therapist, in which she likes being around music, being around people. And when I ask her about her strength, she sees her strength as quite a likable, friendly person who is easy to socialize and connect to people. So when I first met Emily, she presents as a slim Asian woman who is friendly, who is easy to engage. She's quite articulate, but she can be very over-inclusive. She can be distracted by different topics and forgot what the original question was. She's clearly quite stressed with her academic and relationship difficulties, but she's not clinically depressed. She's quite insightful and is interested to pursue therapy, looking into the origin of her mental health problems. So putting it together in formulation, Emily is a 46-year-old Chinese-Australian woman who is a PhD candidate, presenting with academic and anxieties in the context of quite a long history suggestive of undiagnosed ADHD. She also presents with relationship difficulties with Brett and her stepchildren. Looking at her past relationship, she has had fractured relationships from her mother and had an acrimonious separation with her ex-husband. She has academic difficulties. She had identity confusion. She's in her mid-40s, completing her PhD and in the midst of searching for her career. There's also a past history of major depression, but she's not clinically depressed now. Okay. So I just put in here that I think we kind of talk about that, yeah, it's sometimes not easy to find a psychiatrist these days who has his books open. So at this point, if you're seeing Emily, so what are some of the barriers at this point? So firstly, I'd like to mention that is, ADHD is probably the only one condition in psychiatry where it's exclusively treated in the private sector. It's not available in the public sector, unfortunately. And as I said before, partly, because of the COVID pandemic, there's a lot of mental health demand. A lot of our psychiatrist colleagues has their books closed. And compounding to the problem, a lot of our psychiatrist colleagues, they are, for various reasons, they're not, they don't feel equipped to accept ADHD assessment. So it just makes it harder and harder to find a private psychiatrist who can take Emily. Of course, in the private sector, also there are other issues such as the financial cost. It's expensive to see a private psychiatrist. Okay, so now let's imagine we do manage to find a psychiatrist, and yep, Emily is now with me, and I made the diagnosis of ADHD. So what are the options? How are we going to treat Emily? So I guess even before I talk about pharmacotherapy, I usually spend a fair bit of time on psychoeducation. I talk about what ADHD is, what medications do. I always emphasize from the start that medications in most cases are highly effective. It's not a magic cure, it's not a magic pill, it's not going to cure the ADHD, but it's a very effective treatment. Okay, so with the medication, we can then help the patients to develop strategies and lifestyle changes to improve their functioning. Okay, it's a bit like the analogy, it's about helping someone to learn how to ride a bicycle, right? Medications like that trainer wheels we put beside the bike so the patient can learn how to balance. But at the end of the day, the patient needs to do the work. They need to, learn strategies. They need to make lifestyle changes. Okay. So I guess the other thing, before medication, we always talk about we need to have some pre-treatment workup. So in this case, I organize an ECG. ECG is something that I always do. Is often it's normal, but it's a cheap test that you can pick up things and for example, maybe a fundus branch block that may be asymptomatic. That is it's really good to pick up. I also organize a thyroid function test, given her history of thyroiditis. And also, always like to do some collateral history. So I've spoken to her partner, Brett, confirms the collateral history, and I always try to involve the family in monitoring the response to treatment. And I also refer her to see our psychologist, our psychologist colleague who is experienced in seeing patients with adult ADHD. So in terms of pharmacotherapy, I started Emily on dexamphetamine. Initially 5 milligrams twice a day, and gradually basically increasing the dose. So dexamphetamine is a short-acting stimulant. So if we kind of take a step back, what are the options of ADHD medication? So first of all, we have the stimulant medication versus the non-stimulants. So we often find that stimulant medications tends to be a lot more effective than non-stimulant. So we usually pick the stimulant first, provided there's no contraindication. We then have the options of whether we're going to pick the short-acting and the long-acting. Often that comes down to patient preferences. And then we have also the option to go whether we're going to pick methylphenidate or dexamphetamine. So I often tend to find that methylphenidate works better for the children and adolescents, whereas the dexamphetamine tends to work better in the adult population. So that's why in this case, I picked dexamphetamine for Emily. So I asked her to take it every day. And I think, if you have ADHD, it makes sense, you take it every day because you're going to have ADHD every day, right? And I think it's good to, for her to develop this as a routine, to get used to the side effects and to really build up a good momentum and rhythm to the treatment. I asked her to monitor her blood pressure, heart rate, and her appetite and the weight. Stimulant medication, including the dexamphetamine and methylphenidate, it's a bit like coffee. It can increase your heart rate and blood pressure, so it's good to monitor it. It can reduce your appetite, so it's a good idea to monitor your appetite, your weight. And I asked her to continue with her antidepressant at this stage. So I talked a bit about contraindications earlier. So I guess some of the contraindications that I think before we started stimulant would be conditions such as, when someone has a history of eating disorders before, any history of substance use or psychosis. Yeah. So Emily was started on the dexamphetamine, and wow, there was a clear response. The typical response you would expect. She talks about her, after the treatment, it makes her mind more clear in her head. She's much calmer in her affect. She's able to wind down, finally. She's able to get some sleep. Her productivity has improved. She's getting more things done at uni. She's able to manage time to settle down her stepchildren in the morning, and she feels that she can emotionally connect better with them. She's not relying so much on her obsessive coping strategies to keep her organized. So as I said, I started her on the dexamphetamine on 5 milligrams twice a day, and we gradually increased the dose, and she needs to take around 10 milligrams twice a day to feel the difference. So Emily tolerates the treatment quite well. The main side effects she found was appetite reduction, and she did lose a bit of weight. And I think that's mostly to do with appetite suppression. And also I think that is, because of the treatment, she's now has so much productivity. She's getting very preoccupied by work, and she sometimes forget to eat. I sort of reiterate to her that, the good effects from the DEX is great, but it's not the end. So I always encourage patients, they need to keep, try to read more about ADHD, to learn more about strategies. And Emily's, the type that she's so motivated, she loves to read books. So I recommend 2 books to them. And I find that this is really good resources for our GP colleagues to share to patients. So the first one is called ADHD 2.0 by Dr. Ned Holloway. And the second one is called Scattered Minds by Dr. Mate. And the last one is called the Attitude website. So they're all very useful resources. So just try to Google it. I'm sure you can find links to those books and websites. So at this stage, you may think that, wow, treating ADHD is easy, right? But I think we need to remember that we are treating the person with ADHD. We're not just treating the disorder. And people with ADHD, by the time, particularly, they're adults, they have undiagnosed ADHD for many years, they often comes with their own emotional vulnerabilities, their baggage, and their weaknesses. So, for example, Emily, 46 years, she's been living with undiagnosed ADHD. So there was a lot of emotional baggage. So I think the first thing is having the diagnosis itself can be a very liberating process. I mean, it's also quite a mixed emotion. Firstly, she is excited. She's able to find a reason of her suffering all these years. It's a bit like, well, finally, she can pinpoint why she's an ahead, why is she so distractible. There's also a bit of grief of the lost time. She asks, well, what if someone has picked up the diagnosis earlier? There's a bit of identity confusion as well. So she used to think that, well, I'm dumb. That's why I need to work harder. But now she realized that ADHD actually explains a lot of the difficulties. So she's not dumb. So how does it make sense? How does this new identity make sense? So she enjoys being an academic because the intellectual pursuits keep her stimulated, bring her out of the misery. So she asks, how do I combine this new identity and my ability to form new goals for herself? So as I said before, she's about to complete her PhD, and it was just in the final crucial stage to think about this question. So she's really anxious. How are we going to process all this information? And I think also there's a lot of concurrent life changes, challenges. First of all, there is definitely a lot of lack of postdoc job position and teaching roles in the university. And when I saw her, we are still in the COVID pandemic, though. So there are a lot of changes. So I think a lot of this make her feel quite uncertain about her career and her life directions. She also asked me, whether or not she should disclose her diagnosis to her colleagues, which is quite common. Patient asks us these questions. And I always will say that it sort of depends. If you have a supportive boss or supervisor and there's scopes, we can make adjustment to your study, to your workplace, well, then maybe it is a good idea. But not always the case. So we talk a bit about low self-esteem. I think that the identity confusion in this case could also be contributed by quite a long standing of low self-esteem. We talk a bit about she used to think that she's dumb. She's really critical for herself. And so over the years, she needs to rely on achievements to prove herself. And then this is compounded by many repeated disappointments and failures to find the right career, to hold down the right jobs in the past. So this has made her self-esteem go lower and lower over the years. In the past, she used CBT techniques she learned from her psychologist to challenge her negative sense of self. And she feels like there's always something missing, that it doesn't explain the whole picture. So also, there's also some issues relating to, in her developmental history, there's some abandonment from her mother. Her mom has always expected the best of her. And so there's also a lot of, as we said before, a lot of relationship difficulties, a lot of fractures relationship since, she has been together with Brett. So yeah, treating the ADHD is good, but we also need to think about these problems. So over time, with the medications, with all the coaching, so Emily's career, her academic career is showing some promising results. Her skills and achievements is recognized by peers and her students, which just it helps her to clarify this is what she wants to do in her career. Her sense of identity has improved. But then we need to then focus on the other big aspects, which is her home life, which remains to be a problem. So we talk a bit about, well, Emily, she always sort of takes on a lot of work, takes on a lot of jobs. So she sees herself as the auntie of her stepdaughters, whereas Brad is the passive avoidance. And so Emily sort of is the one who organizes the life of the family and take care of the emotional needs of Brad's own children. And Emily would be scolding and nagging her stepchildren. So that creates a lot of conflicts. And she realized that those are really not her role to do this. So in therapy, we help her to set boundaries. We help her to sort of clarify, who are the emotional responsibility in the household. And she also finds that, it's good to, she has to set more clear boundaries. Otherwise, all the household chores and errands fall on her solely. I think as a result, over these problems, so Emily has been feeling quite underappreciated because of these family stresses. She looked quite burnout. So over the coach and the psychology session, we help Emily to realize this. So we've let her know that taking care of others is important, but at the same time, it means she's not spending enough time for her own self-care. So we help her to set boundaries, to talk to Brad, and told him that he needs to be more involved in the care of his own daughters along with his ex-wife. So over the months, after I saw Emily since the diagnosis, on the whole, Emily is making good progress. Medication is working well. She's better in her career pathways. She's clearer in her identity. She realized she is distractible, but not because she's dumb, but rather having ADHD means that she needs to find the right channel and she needs to have the right techniques to sustain her attention. So that's something that our psychologists also sort of give her give her some techniques to improve concentration. So, and she practiced these techniques to restructure her work into smaller tasks and to give herself more breaks in between. So she's really thriving with all these changes, and given the right amount of intellectual stimulating academic challenges, but not too much. She's enjoying the creativity. She enjoys the people, and also in general, the academic environment at the university. It just makes it a really good fit for her. We find that she's a lot calmer. She's a lot relaxed compared to when I first saw her. She has greater self-awareness. Her relationship with Brad has improved. So all of these are validated and integrated in the session. And Emily said to me in a recent session that she said she has been more generous with herself and references examples of being less rigid with the household matters, and she's less stressed by them. So we are at the point that Emily has made really good progress, and her treatment has been stable for over about a year. So one of the things that I guess I want to bring up, and maybe we can talk about again in our discussion, is some of the patients will ask, so can I get the stimulant medication script from my GP? Could I sort of maintain the care with the psychiatrist, but also have a co-share care arrangement with the GP? So we always talk about it is an option, And under the New South Wales Health, and I've put the link that it is an option, but we need to fulfill certain criteria. Firstly, the patient has to be clinically stable. And by that, we often sort of define it as the patient has been on a treatment for over a year with no change with the dosages. In terms of risk, we need to take care of this. As I said before, there's no risk of substance use, diversion, or any drug-seeking behavior. There's no doctor shopping. And so how do we know that? Often we can tell by, is there any, any times when patient come in early for early release, or did they lose medication on a number of times? And also we think a bit about clinical risk factors, such as whether there's any history of cardiac disease, arrhythmias, tic disorders, dyskinesia, or psychosis. So I think that in general, if we can satisfy ourselves that there's no, clinical risk factors and other sort of risk factors relating to, misusing the medication, I think that is something that we can bring up with the GP. I mean, I always have a courtesy letter to ask the GP whether they feel comfortable to do this before I sort of write a letter to authorize the GP to take over the care. So I guess this is our last slide. So to kind of put it in a summary, I hope that we have provided this case study, which is going to be helpful for us to think about what's the role of GP in adult ADHD management. So we talk a bit about, well, it's important that, as a GP, you will see increasing number of patients, self-presenting to you, requesting for an ADHD assessment because maybe they heard about from the news, maybe from YouTube's or from TikTok, or sometimes it could be their family members. Often it's the children who got diagnosed, and the more they read about it, it really explains the symptoms to a T. So the adults now, the parents now, they come to seek assessment. So we talk a bit about, it's difficult sometimes to be able to refer to a psychiatrist on time. So some of the questionnaires we talk about maybe is a good way to start the discussion. We talk a bit about, well, how do we facilitate referral to see psychiatrists? Maybe sometimes it's good to do some, background medical workup. So for example, in this case, do some thyroid function tests, make sure medically is the patient stable, maybe check the ECG, check the heart rate, check the blood pressure, because those are the things that maybe before the patient get to see the psychiatrist, these are the things that medically the patient could be stable. So stimulant medication could be considered. I think it's good to maybe consider also some psychiatric comorbidities. We often talk about depression, anxiety is very common. So perhaps antidepressant to try to stabilize the patient's mood, and anxiety could be something to start. We talk a bit about maybe doing some physical checkup for patients who are on stimulant. So, it could be done, I think at the start of the treatment, maybe once a month, every 3 months. But I think once the patient is stable, the guideline is good to do a ECG, do a repeat blood pressure, heart rate every 6 months. So I hope that with time, you will develop more confidence to provide ongoing care for patients who are on stimulants and potentially, take over the prescribing. So on that note, I'll pass on to Kenneth to make comments, and we can answer any questions we may have.
Great, thank you very much, Dr. Chen, for a really comprehensive talk, and I think that's really pitched at the right level. And judging by the number of participants in this talk, and there's obviously a lot of interest in this area, myself included. I just want to perhaps just go through some of the questions that we have from the participant. I'm just going to go through them and whether see whether they can comment on that, Dr. Chen. That's actually from the Q&A. So what I'll do is that I'll probably just looking at, I think I'll go through probably at a different level. And I think someone is actually perhaps asking one question about, that's a good question, just to remind us in terms of how the stimulant works. I mean, it's almost like a contradictory, isn't it? It's like someone who are hyperactive, but you give them stimulant. And I believe something to do with the prefrontal cortex. But would you like to comment on that? There's someone that's asking about the basic pharmacokinetics, I guess. How does it work in the brain?
So I know. I think stimulant itself is quite a misnomer, isn't it? You know, it doesn't make sense. I think maybe a better word for stimulant should be, I think it should be called like maybe cognitive enhancer, which will give a more accurate description of what it does. So essentially, a lot of this, the stimulant medication, whether it's dexamphetamine or methylphenidate, we are talking about boosting up the dopamine and the noradrenaline in the synaptic levels. Predominantly, we focus on the prefrontal cortex, okay? And but I think it's not just in the prefrontal cortex. We know that there are connections between the prefrontal cortex to other areas of the brain, such as the amygdala and even the cerebellum. Yeah, there's been increasingly talks on cerebellum role on, you know, in I guess the pathophysiology of ADHD. So I think it's about the chemical pathways of those dopamine pathways, the noradrenaline pathways in the prefrontal cortex, down to the, I guess on the lower levels to the subcortical region. And what stimulant medication do is, I'll say most, all the stimulant, they're very short acting medications, such as dexamphetamine, methylphenidate. It only lasts for about 4 hours, roughly. The long-acting one, it could last a little bit longer, maybe 8-10 hours. But by default, you know, the next day, if you stop taking your stimulant, the patient will feel that they are sort of back to square one. Yeah, so it doesn't really cure those dopamine imbalances. So I think that's why we use the analogy that, you know, medication is just gonna give you a push. We want you to, it's like learning how to ride a bike. We put the trainer wheels beside you so you can learn the skills, and the medication itself is not gonna cure the ADHD. Okay, but with the right, I guess the lifestyle changes, the more you understand your strength, the weaknesses, you're able to live better with ADHD. Exercise is also good. Exercise is also going to boost up the dopamine. You know, for example, you know, some people find a lot of exercise like involving coordination. For example, the ones that activate your cerebellum, that often helps with ADHD management. So I think that gives you a sense that stimulation works, but it only works in a certain level. That there has to be other lifestyle changes to sort of optimize ADHD management.
Absolutely. And I think also a number of participants was asking about what are other non-stimulant medication that you mentioned previously. Was there any specific that you would recommend to use?
Yeah, so there are other non-stimulant medication options. First of all, there is one called Catapres. Another similar one is called guanfacine. Okay, so the trade name is clonidine and intuitive. So they works a little bit different from stimulant medication. They're more like the alpha receptor antagonists. So they work by helping the patients to be less impulsive. So we find that often people, if they are quite hyperactive, and they find it hard to relax, wind down, this sort of, catapress or intuitive is a good adjunct to the stimulant medication. It can also be used on its own. There's also a non-stimulant. It's called atomoxetine. Atomoxetine mainly works on the noradrenaline pathways, but it can be. I mean, we do use it sometimes, and I mean, some patients, for whatever reason, they have contraindications. We are not keen to start a patient on stimulant. Atomoxetine could be an alternative. Yeah, one thing to be aware of is we need to usually start the dose pretty slowly. So start with 10 milligrams and increasing it very slowly. Often I just start really slowly, 10 milligrams, and increasing it by 10 milligrams weekly. Otherwise, the patient finds it really hard to tolerate.
Right. There's also a number of participants asking about in terms of other type of treatment, for instance, things like neurofeedback, biofeedback, and some people mention about patients spending a lot of money for that. And what's your thought on those treatment?
Yeah, so neurofeedback is a emerging treatment. I think there is a lot of talks, a lot of interest, because of course, people are interested because it's a non-pharmacological options. I think looking at the evidence base so far, a lot of the treatment guideline is not a lot of level 1 evidence to support. Yes, that's something you definitely will recommend to the patients. Not like stimulant. Medication is kind of the level 1 is kind of on top. Neurofeedback is we don't have a lot of good, level 1 evidence yet. I'm not saying that it doesn't work, but it's just treatment. I think we still need a bit more, I guess, a bit more research done in the area. It's a bit of a commitment. You need to, to have the sessions multiple times a week for 20 sessions or more. So it's a bit of commitment, and also, yes, the financial commitment as well. So yeah, so I think I think
so that's basically a treatment that's a lot of unknown, isn't it?
Yeah, at this stage.
Yeah, we've got an interesting question just and a participant sent off and mentioned about one of his or her patient was talking about being more focused when using cocaine. I think that's already ruled out the possibility of having a treatment. Someone using cocaine, being more focused. And then also mentioned about the use of caffeine to manage or even test diagnosis of ADHD. And I suppose if caffeine is a stimulant on its own, and a lot of the energy drink that nowadays is available in the market. What's your thought on that in terms of caffeine? People using it themselves. And
I think we mentioned earlier that comorbidities are common in ADHD, and often people with undiagnosed ADHD, they do rely on substance, and caffeine or coffee is one of them. Not uncommon to see patients who are on a lot of coffee to keep them stimulated, keep them concentrated. I wouldn't say that this could be sufficient to be a diagnostic test itself. And I think I'm not against people drinking coffee with the stimulant. I think we just got to be sensible. You're adding 2 stimulants together, so it's more likely you may get your heart racing and palpitations if you mix the coffee and the stimulants together. Some people don't notice it as a huge problem. Yeah, but some people do find that it sort of makes them more increased heart rate. So just be careful on that.
And also speaking about treatment, there's also a number of participants asking about some ADHD coaches versus psychologists. Any comments on that, Charles?
Yeah, so I mean, the main difference I see between psychologists and ADHD coaches, psychologist tends to be the one who is going to be more looking into the depth, the cause of the problem, using CBT, ACT, schema therapy, different approaches. Whereas the ADHD coach is maybe not focused too much about the past, but more on practical, more on strategies, how to develop techniques. So, so coach, they often tend to meet with the patient or the client maybe once every fortnight or even once a week. They're going to do homework. They, the coach will invite patients to bring the problems, and then they kind of sit together, problem solve. I mean, of course, there are some overlaps. I think nowadays we do have more psychologists who are more in tune with ADHD management, and they can do a bit of coaching as well. But I have to say, not all psychologists, I guess they have the necessary training for ADHD coaching. So maybe when you made the referral, do get a sense of whether that psychologist has experiences with ADHD coaching or not.
And in your practice, do you use any coaches, Dr. Chen, or just mostly all psychologists, clinical psychologists?
Yeah, so I used to have both. Unfortunately, our ADHD coach, he is actually originally from the US. So he's actually gone back to the US for family reasons. But at the moment, we have psychologists who can also provide ADHD coaching. Yeah, I mean, if you definitely our GP colleagues can look onto our clinic website. You'll be able to see on our website.
Absolutely. And speaking of in terms of some of the treatment, I can see some queries regarding the use of medicinal cannabis. So I don't know, what's your thought on that in relation to ADHD? It's been used for many, many conditions.
Yeah. Look, I think we said before that often people with ADHD, they it's so the mind is racing. They're actively looking for something to slow down their mind, and cannabis is one of the solution they often goes to, whether it's the recreational or the medicinal cannabis or prescribed by other prescribers. I think I think the treatment guidelines so far is there's a bit of a gray area. It doesn't absolutely say no to mix the medicinal cannabis in stimulant treatment, but it's just something I'm of course we have to be cautious mixing the two together. So for example, I usually have to maybe contact the pharmaceutical regulatory unit to make sure I get a okay before I prescribe, either of them. Yeah.
Okay, so it's certainly not a contraindication if someone's using it sometimes for other conditions, I guess.
Yeah, maybe not. I wouldn't say contraindication, but I think we gotta be cautious mixing together.
And also there's a question regarding that in terms of contraindication about patients who suffer from seizure and also as ADHD. Is stimulant medications safe in these situations?
Yes, seizure itself, I don't think it's a contraindication.
Right.
But yeah, of course, in cases like this, we always, use the principle, go slow and start slow. And particularly, if a patient is on an antidepressant, potentially, the medication could lower the seizure threshold. I don't see it that often, but it's, again, just be cautious. I don't think it's the contraindication as such.
Okay. And there's also questions about, in terms of geriatric patient with ADHD. Do you have any experience in terms of treating, I don't know, we'll use the term geriatric patient as anybody above 75, 65? I don't know. So interesting question.
Interesting question. And I do definitely have more. I definitely have patients who are more than 65 years old and coming to see us for treatment. When actually, it's interesting. I think I talk about people usually live with their ADHD undiagnosed for many years with their own scaffolding, with their coping mechanisms. And actually, one of my patients, this patient, he's actually he's a school principal, and he used to have so many people working for him. So this is his scaffolding. He's really good with people, and he's good at getting people to do things for him. But once he's retired, the scaffolding has gone, and he started to, well, I guess, realize there was a lot of problems. And I think equally, when you think about many years ago, they don't talk about ADHD. So a person who is 65 years old is also going to be very likely to come to see you because they just heard about ADHD in the last few years. So it can happen. And of course, in an elderly patient, we got to be careful with pharmacotherapy. I think, go slow, start slow. There's likely to have more probable medical issues we need to be careful of, such as cardiac problems, arrhythmias, high blood pressure, these sort of things. But provided if we can keep these medical issues under control, it's definitely not a contraindication to start someone on a stimulant, even if they're over 65 years old.
Provided that you can exclude, make sure they don't have any cardiac problem, like what you mentioned previously, obviously. And there's a question about whether ADHD is genetic.
There is a lot of biological components, and there are many genetic studies done on ADHD, and some studies even quoted up to close to 85 to 90% of the genes being passed on to the offsprings. So this is a very biological and genetical hereditary condition.
I think we see that in clinical practice often nowadays. Is the kid's been diagnosed and then the parents come in later on asking, do I have that condition? And I think that's very common. I see that in my practice quite a lot nowadays. Thank you. And also, that's a good question. I think a lot of questions coming through are asking about treatment, obviously. I want to also touch on, this is a good question regarding monitoring and follow-up. I think there's a participant raised a very important question about how do we monitor patient? I mean, they've been treated and they actually, we GP still dealing with them on a daily basis, and mentioning about monitoring. How do we monitor their progress? Be it, I mean, for instance, we use a simple tool like the analogies using K10 in terms of assessing anxiety, depression. Do we use similar sort of tool or similar, that screening tool that you mentioned previously, that purely for screening, but what about in terms of monitoring? Do you have any particular tools?
So those screening tools that I talk about, it can, I think, I sometimes use it to track progress as well. The screening tools, they're very easy to administer, it doesn't take the patients a lot of the time. Yeah, I think we can use that. And in terms of what other parameters to monitor for, I think we talk a bit about, particularly about the cardiac side effects, such as monitor the heart rate, monitor the blood pressure, and do an ECG at the start. I mean, how often do we repeat? It sort of depends on the, I mean, if you have someone who has no cardiac issues, I think in general, maybe we can do it every 3 months. And then if patients are pretty stable, we can do it every 6 months, unless if there's a change with the dosages. I think
you're referring to ECG, is that correct?
Yeah, maybe ECG or the OBS blood pressure and
blood pressure, yeah.
Heart rate. Yeah. Appetite suppression can be, I mean, it can happen. So maybe a good idea, if the patient hasn't done it themselves, maybe check their weight.
Check the weight, obviously, we do.
Yeah.
Yeah. And obviously, you mentioned about patient with previous history of eating disorders are probably contraindicated in using such medication, obviously.
Be very careful. Yeah.
Yeah. And I think at the beginning of the talk, I think there's a number of participants obviously quite interested in about knowing, do we have any sort of a list in terms of psychiatrists to have an interest in assessing or in treating patients with ADHD? I believe you have a special interest group. I wonder whether you can tell us a bit more about that, Dr. Chen. That would be useful to have some sort of a list for us GP to know who to refer to that can do assessment. Obviously, these are not through public system, as I can understand.
Yeah, I'm with I'm a member of this group. It's called AADPA, and it's a multidisciplinary group, including psychiatrists, psychologists, clinicians, researchers who are interested in ADHD, including children. So they're pediatricians in a group. And the AADPA is actually, they're actually forming like a directory of clinicians who, who are able to take on new referrals. I think from what I get, it's not up and running yet. Yeah, but it's something that maybe, we can watch the space. In terms of our own College of Psychiatrists website, if you just Google RANZCP, so RANZCP, find a psychiatrist, there is actually a website. I think it's called Your Health in Mind. So you'll be able to find psychiatrists. So you can sort of specify your search that you want to find psychiatrists who are accepting ADHD referrals. So that's that one is up and running. So you can use that to kind of narrow down in which suburb you're looking for a psychiatrist who can take ADHD. Of course, it doesn't guarantee that the psychiatrists still have their books open. So you still need to call and ask. I mean, I work in a psychiatrist clinic. As I said, I mean, we're not an ADHD clinic, but we a lot of our psychiatrists, we are interested to take on ADHD assessment and management. So you can have a look on our website. We still have our most of our psychiatrists still have our books open.
Sure. I think what we'll do, we'll perhaps get our coordinator, I think Lydia will collate some of those information, especially about your special interest group. Hopefully they will have some sort of directory up and running. That will be really useful. And for some of our members' sake, I believe, I just looked it up, the college do have a special interest group in
Yeah.
ADHD. I believe the current chair is Associate Professor John Kramer. I'm
Yeah.
not too sure whether they have a directory. I haven't actually seen one, but it's actually under the what they call ADHD, ASD, and neurodiversity special interest group.
Yeah.
As well. So probably coming back to a little bit about still got a lot of questions coming through about treatment. And I think one critical one, I think I spoke to you previously before, and I think that's probably quite useful for us GP to know is in terms of treatment, in terms of duration of treatment. What's your thought about in terms of how long do we treat them for? I mean, are they going to stay on that forever, or at what point in time do we stop, or do we reduce the dose? Would appreciate your thoughts on that.
Yeah. So I think it goes back to what we said earlier, that stimulant medication is not going to cure the ADHD. So often, the time frame we're looking at would be, patients will be on the medication for years. It takes time for them to, I think it's all good to say to change your job or lifestyle changes, but I think the reality is you need to give them the push, to give them the right support before they can make changes. So often, patients they do need to take medication for years. I mean, the natural pathways, some of them, they, of course, maybe they, find, I mean, I've got patients, they have developed a lot of good lifestyle changes. Some of them, they really enjoy running, exercise, first thing in the morning. And anecdotally, they do feel that they can rely less on medication with time. It doesn't happen to everyone, but there are a lot of this kind of lifestyle changes that can make people kind of less rely on medication with time. It may be also the patient will be relying less on medication, but for example, when there's some major life changes, maybe when they get promoted at work, or they kind of sort of finish high school, they go to university where there's a lot of demands in their study, in the workload, they may need to put back onto the medication to help them to get through those transition period. So really there's a lot of factors like that is involved to decide how long a patient should continue for, when to stop.
I guess it's not dissimilar to some of the children, isn't it? Having ADHD. I mean, they've been on it for many, many years, and a lot of them actually use it, for instance, during school term or school days, and then leave it off for the weekends when they're a lot less stressful, so to speak, and they don't have to focus. And the next question actually comes to also asking about, in a way, children that grow up to become adult. And often they'll be transferring out from the pediatric service to the adult. And the question is about, patient or children becoming adult who are already on stimulant and stable. How do we smooth the process for them? I guess I'm not too sure whether that at this stage there was actually any formal process. And I suppose sometimes the pediatrician would say, I want you to refer them to a psychiatrist, or whatever, to continue on the treatment. And what's your thought on that, Dr. Chen? Or do you have any comments on that in terms of children going on to adulthood?
So I think I'll say that we do see a lot of teenagers. They turn 18 and they sort of graduated from seeing pediatrician to now coming to see adult psychiatrists. So and as adult psychiatrists, most of the time we will still take it as a new patient. We will still take a thorough history, get the collateral history from the pediatrician. But often, if we're satisfied with the diagnosis, we will continue the treatment. I guess it's a bit of a transition. Of course, pediatrician and psychiatrists, there are some intrinsic differences. I mean, physician, they are more like they are physician, you know, they can deal with a lot of general medical issues, whereas psychiatrists, we're sort of we are more kind of focused on the mental health. I mean, we do our physical medical stuff, but I think not as in that details comparing to our pediatrician. So it's a little bit of difference in terms of I guess the expectation when they transition to see a psychiatrist. Often, you know, of course, seeing pediatrician the family may be involved, whereas in psychiatrists, you know, you're an adult, we expect you to often we respect confidentiality. We don't always get the family in the room, so there's a bit of I guess transition. Yeah.
That's a good point. And I think we GP are probably the main conduit. And I think for that to hook them up, isn't it? In a way, we would be the main coordinator in a way to actually coordinate that service. And I suppose access is the main issue, as a lot of patients a lot of our participants have highlighted at the moment. And I must say, I just fear that in the future we see this two-tier system that basically people who can afford to get treated or to get diagnosed will get treated and perhaps get better, whereas the people who cannot afford won't get treated. You get this divergent two group that actually people will continue to suffer. But I guess that's another talk. That's not for us to discuss with this in terms of the economic difficulty and regarding access. I noticed that there's also some participant was interested in asking about patients being adult ADHD in terms of being able to get onto NDIS. Have you ever had to help patient with the diagnosis of ADHD being able to access NDIS? Dr. Chen, have you ever had a request to like fill in any particular application form? Because sometimes often patient chronic condition sometimes can qualify them to have access to NDIS. Yeah. Which can give them some financial access to other services.
Well, at this, I think there has been a lot of talks on putting ADHD on NDIS as a qualified conditions. Like for example, last year there was a talk. I think I mentioned it earlier. It was one of the web link I shared with the participant. It was a talk at the National Press Club by the comedian M. Rusciano. I think she sort of really passionately sort of advocating to get ADHD onto NDIS. I think Bill Shorten has been contacted by one of, I think, our psychiatrist colleague that there's a lot of push. I don't think it's happening yet, unfortunately. So which is a shame. And I think it is a space that I know a lot of our clinicians, researchers, colleagues are working on. Yeah, but at this stage, unfortunately, I don't think you can get a lot of, I guess, funding just purely from NDIS.
Right. So the short answer is that at the moment, that's not it's not a condition that you qualify to get NDIS at this stage. And looking at NDIS, the blow up in the budget, I'm not too sure how likely that will be. But anyway, that's for the treasurer's problem, not our problem. Also, a question about interesting coming back to that ADHD medication. A number of participants was concerned about the possibility of long-term effect. In particular, there's a question about is there any increased risk about Parkinson's disease or other dyskinesia type of problem with the associated with the use of long-term use of stimulant. Would you like to comment on that, Dr. Chen?
Yeah, look, I think it is an important question. Given we talk about that patients are often going to be taking it for years. And now if we think about the stimulants that we use, like dexamphetamine or methylphenidate, has been around for a long time. we're talking about back in World War II. So there has been a lot of long-term studies. I've read a bit about concerns how if we are sort of acting on the dopamine pathway, is that going to increase the risk of Parkinson's or dyskinesia in general? The short answer to that is we don't have any evidence. I think it's just to do with how the stimulant works on the receptors level, and also it is quite a short-acting medication, and also from the kind of the long-term studies that I'm aware of, we don't have any evidence to support. Some of the more established long-term issues still has to do with the cardiac monitoring, such as increasing heart rate, blood pressure, and in the children population, about, of course, growth, the height and weight, these sort of things.
Right. Yeah. I guess long-term, especially in children, they use it for long-term. There's certainly no report of them having any increase of movement disorder, Parkinson's, so to speak. Is it? I have not personally seen any study in that regard. But great. And I think there's also some mention about. Sorry, there was a question mentioning about whether any certain event can trigger ADHD. There was something talking about trauma triggering ADHD. Are you aware of any?
Yeah, so emotional, I mean, there has been a lot of interest on how is emotional trauma kind of, can it trigger ADHD? I think this one is a big topic. So if you think about someone who have the genetic vulnerabilities of ADHD, by nature, they're more likely, more prone to have developed or engage with some traumatic events because of their impulsivity. So I think that becomes a vicious cycle, isn't it? I think if you have trauma, of course, trauma can induce our HPA axis, and the stress hormones can create a lot of ADHD-like symptoms. Look, it's a big topic. I think, but I think the short answer is, sometimes emotional trauma, or during the developmental stages, it may be something that we do look at closely, and we often ask because it's so common in our ADHD population.
I think in a nutshell, probably saying that it is one of the many factors that can probably trigger as contributing factor, I guess, with that whole mix. And if any of our participants have watched that pre-activity program, that video that Dr. Chen mentioned about, that comedian that actually was spoke about very passionately on the national gallery. I think that the talk was she summed it up quite succinctly, and I think that also led me wonder whether should all neurodivergent patient or people, should they all be treated? I mean, really, and does it actually really stymie their creativity? Really, because sometimes neurodivergent patient or people actually have their own unique ability to be able to perform what they perform. And do we all need to be treated, so to speak?
I think that's really good. That's a really good question. And I think even the word treat or disorder, is that appropriate really? If we accepted the neurodiversity principle, because by neurodiversity principle, we wanted to accept the neurodiverse individual as they are. They're not necessarily disordered. It's just like the LGBT movement. We want to create a sense of acceptance and pride. We want the neurodiverse to be able to feel sort of belong. They feel proud of who they are. We're not trying to treat the disorder. So whether or not they all needs to be treated, I think it still comes down to, well, if there's that mismatch between the makeup and the environment, if they, of course, create distress, it's certainly, it should be, they should receive the treatment or the support. I think, yeah, it all comes down to a lot about the, whether there's any mismatch, whether there's any distress. We need to talk about the autonomy, the wishes of the person. Yeah.
Absolutely. I'm conscious aware that we've got about 4 minutes or so before we round up. May I just also ask Dr. Chen about this question in terms of what your thoughts about this? And I think there's some participant was actually interested in know, and what do you think of that idea about, I mean, obviously psychiatrists are inundated with this, will be inundated, if not already are. Do you think that there will ever be a possibility of GP doing some training and being able to initiate stimulant medications?
Yeah.
What's your thought?
I think, look, I think, as you said earlier, I think it's maybe we should have a forum to discuss it. I think that training GP, of course, there are many different challenges. Of course, psychiatrists, we've done 6 years of training to learn how to do a mental state. We learn about different psychiatric disorders, how to formulate. It's really, I think it's not easy we would expect to run a course, and we would expect our GP colleagues to be able to make the diagnosis. I mean, yeah, maybe there are some really straightforward cases of ADHD. It is possible, but I just think that we got to be careful. Not all the cases are straightforward. There will be comorbidities. So I think that I'm always open to different suggestions, but I think we need to have that level of, I guess, care in, maybe the solution could be about, psychiatrists, we can assess, initiate treatment, and we can authorize GP to provide ongoing script with the right monitoring system. Maybe that's a good pathway, so the psychiatrists can then focus on assessing new people, new patients. GP then spend more time in follow-ups with the right. Of course, it still involves a lot of training and education. Yeah, and probably that's something that the special interest group in the GP network could. I'm sure they might. I think there's a lot of talks in this already.
Absolutely. I think that's probably as similar to a model that I would actually use an analogy to our antenatal care. And I just wonder whether we're probably something that what we would be looking at will be some sort of shared care. And I think that's probably will be what we'll be looking in the future, I suspect, because as the patient load, there's no way all patient, including especially you mentioned about stable patient, will be able to see the psychiatrist on a regular basis. And I suspect some sort of shared care model will probably be the main, with us GP having additional training. And I think seeing the interest that we have this evening, I suspect that it will be something that we CPD committee will be taking back to our PHN and looking at that. And I think that will be something to start off with. May I just ask you about in terms of that I suppose that shared care model, What would be your thoughts about in terms of how do we run this? Like, I mean, the patient obviously have to agree to that, and we need to agree to that to do that. So in terms of prescribing medication, would you say that the patient must see the psychiatrist at least once every 12 months? And then you mentioned about some of the criteria that they need to stick to, no doctor shopping and no self-increased dose. I absolutely agree with that. And doing some regular tests. What's your thought on that, Dr. Chen?
Yeah. So now, firstly, there are a lot of these criteria are set up by the state regulatory units. So New South Wales Health have their own criteria, and interestingly, in different states in Australia, they all have a little bit of difference in that requirements. So, for example, when you ask about how often should the patient come back to see the psychiatrist, so I think New South Wales Health it says 1 year, but I think in other states it said 2 years. So there's a lot of discrepancy.
Right.
There's a lot of talks that we are going to integrate it into a national system, I mean there has been. I think there has been a lot of interest also to make the prescribing, the SA, the stimulant medication, as a national system. So I know it's been talks for a couple of years at least. It's supposed to be out sometime this year, but I think that would be a really good solution to standardize the whole process nationally. So for me, I think in the interim, if I fulfill all the criteria we talked about, I think every 1 or 2 years, it sort of really depends on the patient's stability. Maybe the patient can come back to have just a checkup with the psychiatrist. Of course, the patient can be referred to see us at any point if there's any concerns about the treatments.
Okay, great. I realize, sorry, that we are actually running over time. But this final question about advantage of having ADHD, and I think you've already answered that. I think it's the neurodiversity is the advantage. I think being creative, I think that's correct, isn't it, Dr. Chen?
Yeah.
But anyway, thank you so much, Dr. Chen. It's been absolutely wonderful to have you to this talk, and I can see that we have still a whole lot of interest, and we still got 90 plus participants still staying online. I would definitely take this on board and actually bring it back to the CPD committee, and I think we should definitely run some follow-up work with this, and looking at maybe even running some little workshop that we can do and upskilling ourselves and stay interested in this area. It's a huge topic. It's going to be an explosion of this in the coming year, I can tell. But thank you so much, Dr. Chen, for giving us a wonderful talk, and thank you everyone for staying so late.